My name is Dr. Eric Griggs. I'm the Assistant Vice President of Community Health Affairs at Access Health in Louisiana. My job is to take care of everything outside of the clinic space. I'm a graduate of Tulane Med School with a transitional residency in family and community medicine. I happen to be a health educator for Fox 8 for the last 11 years. I do on TV every day. My job is to take what seems complicated about our healthcare system and interpret it for the general community. And you know, the interesting thing about this space is that to the community, this is all brand new. It wasn't until ChatGPT that a lot of people found out what AI was, or they don't even know the difference. They don't understand that AI is machine learning. They don't realize that it's been around for centuries. The interesting thing about it is the biggest barrier is most people hate math. I was an English major, right? So they told you reading, writing, and arithmetic. Well, it's all math when you think about it. This is necessary but not sufficient. So it's really allaying people's fears and helping people understand that this is a good thing, and getting as many partners to the table, including the community members, so it can be a comprehensive solution.
Thank you, Dr. Griggs. I'm Lee Mendoza. I'm the Director of the Bureau of Health Informatics in the Office of Public Health at the Louisiana Department of Health. The longer the title, the further you are in the hierarchy. Actually, I lead a team who are responsible for things like the state's health report card, the opioid and drug overdose surveillance in the state. We manage the electronic health record that's in all of the parish health units across the state. We work with researchers to cut data for their research projects, and we're responsible for a good number of the visualizations that you see on the LDH website, including the COVID-19 dashboard that has since been transitioned into something else. So for all the work that we do, we're at a very perfect intersection for AI and machine learning to assist in the work that we do. But data fragmentation is a real thing. It's a real problem for us. When we started looking at COVID tests, we discovered that race and ethnicity was missing on at least 50% of the tests. So we could have done a couple of things at that point. We could have just thrown out all that data and assumed that missing information was equally distributed and represented across racial groups. And in fact, there's reasons to think that that's not the case. Instead, what we did was we combined information from a variety of data sources to help augment the data that we had, and went from missing race and ethnicity information in 50% of tests to having racial completion in 95% of the tests. They gave us a much better data set to be able to describe health inequities when it came to COVID, both in terms of cases, deaths, vaccinations. So we're able to leverage those partnerships to help compensate for missing data. We see data fragmentation in other aspects as well. If you look at our Office of Aging and Adult Services, they provide essentially Medicaid services for elderly and disabled individuals who live in poverty. So being able to trace someone from, as Jason said, a fall to the emergency department, to hospitalization, to discharged to a nursing home, back to home where they might receive home and community-based services, back to the emergency department, is very challenging. We don't have a way of being able to grab data from all those different providers and all those different settings to be able to examine the continuum of care that elderly, disabled people who live in poverty have. And so that's that's an incredibly fragile population. I mean, these are our parents. Sometimes these are us, right? So being able to learn how they interact with the healthcare system, being able to look at precipitating factors, being able to look at health-related social issues to see how that informs people's time course of disease is incredibly important. So I think AI can be leveraged in those instances. We see other states, California is using AI right now to predict who might be experiencing, who's at risk for experiencing homelessness. It's an incredibly expensive proposition to be homeless, right? You might spend $35,000 for each person who's homeless, whereas keeping them housed costs a little bit more than half that. So it's much more expensive to let people experience homelessness rather than prevent it. So I think there's great promise. I think there are certainly dangers and things we need to guard against. We certainly don't want to exacerbate any existing health disparities. But I think that with proper governance, with great thinking, maybe turning AI around and helping it guard against bias, I think that we can make great headway. Sorry, I'm taking up a lot of time. Go ahead.
Good morning. My name is Jeffrey Quo. I'm an emergency medicine physician here at Oxnard Health. My primary responsibility here is actually as our system chair of patient flow and EMS. I will say that folks ask me all the time, how do you get into the roles and responsibilities that you have within the health system? And my answer, number one, I have the coolest jobs of anybody, perhaps in the country. I have the opportunity to go watch football and get paid for it. I'm one of the team physicians for the Saints. I run medical operations for Jazz Fest. But beyond that, I think that a lot of what I tell folks is that it's happenstance. You have to have the right education background, but then ultimately opportunities arise. Much like sitting at this panel. I'm sitting amongst folks that are clearly way more educated than I am on this topic. And to be perfectly honest, this is extremely humbling for me. What I will say is that my first experience or exposure to AI and ML was really just harebrained ideas that I came up with because of my responsibilities as an ER physician and as our medical director and chair of patient flow. And the reason is because I saw the health inequities that a lot of our folks within our region and our country were facing, despite the fact that we're supposed to be the strongest country in the world. And I think that there's such significant inequities that we have to do something about it. And so I started reaching out to subject matter experts and saying, hey, why is it that if I am someone of a lower socioeconomic status, living in a small community outside of a large city, that it is so difficult for me to have access to health care? And the answer is the economics of it, right? And it's an unfortunate situation that we find ourselves in this country where there is such disparity from a financial perspective. And so I took it upon myself, because my organization has been striving to improve on the overall health of the state of Louisiana, trying to move us from the bottom of the country to somewhere a little bit more respectable. I felt like it was my responsibility. We were going to take that responsibility on as an organization. And I feel like it is my responsibility to do my part. And so I reached out to subject matter experts and said, I need to figure out a way to get more patients seen in a more timely fashion. And that was the simple premise behind how I got involved in some of our AI and ML work. I reached out to our folks and said, how do we go about predicting based off of known factors, discrete data that we already have in our EMR, things such as the patient's medical conditions and what their diagnoses are, what their labs look like, what their current vital signs are like, and then taking historical data, things such as today is a Tuesday in April, and we know that we are 2 days away from the beginning of Jazz Fest, so there's going to be an influx of people coming into our town, and the weather is this, and the pollen count is this. Can we use machine learning to predictably identify how significant of a surge we're going to see in our emergency departments across our organization and within our region? And then beyond that, then, can we leverage technology to say, not only do we want to be able to predict it, but we want to become prescriptive with it and say, because of what factors are ongoing today, we can expect that on Friday morning at 9 a.m., this is what's going to be happening. What can we do? What can technology tell us to do to avoid what will happen at Friday morning at 9 a.m.? And that's really where it started. I reached out to a bunch of folks that were way smarter than me. And all I did was come up with some harebrained ideas and then let them run with it. And we've been really working towards this for quite some time. And I'm really fortunate to have the folks, and I see a lot of them in the room today here, that I've been able to work with. And so I'm really humbled, again, to be here. And I'm really excited to learn from so many subject matter experts today.
Good morning. I'm Andy Sanchez. I'm the Officer of Health Innovation at UL. recently joined the university, came from Boston, but I am originally from Colombia, where I did med school. I want to say that my training was like I'm a general physician, trained like with a focus of family medicine, community medicine. Had the opportunity to practice there for a while within rural communities and what I call real public hospitals that have all these needs that you probably imagine, and in a developing country. And then I moved to Boston probably 10 years ago, and since then I have been doing research. Research focused on improving the move to digital platforms. So yes, I do not have experience in AI, but I do have experience working with all these underserved communities and kind of thinking in these solutions, doing community engagement to work with the real community to kind of think in how to improve all the healthcare system and a system that will work for all of them and not for just a group of people that is usually the patients that are more privileged and that are able to seek care.
Apparently I need to learn how to use the mic. Griggs is helping me out. I'm going to go to the first question, the next round this
I
time.
learned from a machine.
Thanks everybody for those openings, and the original first question that we had laid out was barriers to access to the right information, and we're going to stick with that. However, Lee, in your opening statements, you talked a little bit about the ways that you were able to overcome those barriers with data augmentation, so I'm just going to stretch the right? So it's what are the barriers to access to the right information, and how might you overcome those through data augmentation?
So I think it depends on your goal. Your goal is short to medium term gains. And I think working with partners to combine data from different data sources, using data matching techniques, I think those techniques help. If your goal is longer term, to prevent people from being so sick that we end up at the bottom of every list, then looking at something like legal epidemiology would be incredibly helpful. That is the systematic and scientific study of the impact of policies and laws on population health. We have enough data across the country, laws and policies, and we can see health outcomes that are a consequence of those policies and laws. Where being able to use something like AI, figure out what helps, what hurts, and what helps. I think being able to use AI in that context really give us some powerful tools to improve the health of people in Louisiana. I may have gone a little afield there, but I wanted to address something a little bit more than just the one.
Great, thank you. Jeff,
I'm going to answer this on the flip side, right? Why is the information important once the experts are able to grab it for us, right? And I think that ultimately, as a healthcare provider, we need the information in order to care for patients. But from a technology, AI, ML perspective, I think that getting granular with this information, not necessarily on the public health side of it, but for our own patients, is extremely important. And what I tell folks all the time is, a lot of the work that we're doing is behind the computer, right? Or the computer and machines are actually doing a lot of the work for us, but the inputs are the key to this. And ultimately, it translates into lives being saved. And so anytime I'm presenting anything that has a tremendous amount of data associated with it, what I always end with is, this is the actual lives that we can save with the opportunities that this technology is providing to us. And so a lot of the work that we've been doing is trying to grab data and then identify opportunities where we can save lives, such as what Jason mentioned earlier, algorithms that are running in the background of our EMR that are trying to help us identify when a patient's clinical status may deteriorate so that we can catch it beforehand. And I think that that's so important, but without the data, it's impossible to do. And so what we are seeing here within our organization from a patient flow perspective is that upwards of 70% of all of our patients that we are bringing in from external facilities to our main hub here, for instance, are actually coming from facilities that we already have the access to some of their data. And I think that that's key. So we can run models in the background of our EMR that are identifying which ones are the sickest so that we can then optimize our workflows to be able to say, this one we need to target and bring them in now. And this is getting really granular. We're talking about on a patient-by-patient basis. But the idea is to identify those with the data that we are being provided so that we can save the lives that we can potentially save patient by patient by patient.
I want to add, I probably will answer your question with another question. It is more related to what things can we do to diversify our target or our population. So the thing is that I'm more concerned about having an algorithm with bias because we don't have like enough diverse population in our research population, right? So we are designing all these studies or in this case, machines without being sure that it's going to work for everybody. So I think that we are in need, yes. I mean, everything is growing and is evolving, but at the same time, I think that we are in need to work together with communities to make sure that everything that we are planning to do will work. And what I want to say with this is that we cannot allow like doctors in general to dehumanize the medicine, to be just like behind a computer and just like doing whatever the software says. So I think that one of the solutions of those barriers will be working together, just like since we are like from the research design, kind of understanding what all those limitations are and trying to bring to the table those partners that can help us to understand those barriers and also provide solutions together.
So I'd like to expand on that even further and allude to what was brought up in our keynote. In the addition of the audio augmentation, it's more data. What happens is, and I experienced this firsthand, I was for this region, I don't know if anybody's watching, please. I was one of the faces of COVID for the region. And the biggest barrier that we face in healthcare to AI, machine learning, or anything new, particularly those two, is fear. We fear what we don't know and we don't understand, like math, right? Sprinkle a little math and everybody's scared, right? Well, this is a new jargon, and this has been sensationalized. Some of our smartest traditional computers are preschoolers compared to the way things have moved and are moving. So with the addition of novel ways to use machine learning, like audio capture of the patient interaction, you can learn the cultural sensitivities that you allude to can be picked up and be added. That data can be added to the front side of the inputs so the outputs can be actionized, and then it comes to me. I get to come on TV and teach people that English is math and say, don't be afraid of it. The addition, part of what I do is I'm wearing a Freestyle Libre on one arm and a Dexcom on the other, and I'm not even diabetic. Because I have to teach people not to be afraid of what's happening. This is a good thing. It's been around for decades. You just have to take the time to talk to subject matter experts and people that you trust. I'm not alone that.
You want to continue talking about lines?
Yeah.
So, Dr. Sanchez, I appreciate that very much. I mean, we know that there's a great danger of bias. We've already seen that in machine learning algorithms and AI. There are a number of frameworks that help guard against that. I think the FDA has a project with the UK and with Canada that describes how to look at bias throughout the software development lifecycle, or called the total product lifecycle. Right? Abramoff, a physician and a researcher, he also goes into great depth of explaining at each stage of development, from concept to development to calibration to deployment to evaluation, what potential bias could exist and how to measure it and how to remediate it. So I think instituting those types of frameworks when we're developing AI products is critically important.
Which also goes to further, when people think bias, they automatically think some type of resource bias or cultural bias. There's different classes of bias in the machine learning world that are addressed. There's historical bias. Back in a time when there was it was only male that we worried about, there was a historical bias. When you talk about patients with heart attacks, right? The recommendations were all for men. And it turned out that women have, got a subject matter expert smiling over there, women have different signs and symptoms. Then there's, of course, the representation bias that we all know about. So it is something, but again, it needs to be brought to the forefront so people know about it so we can be less afraid of it.
All right, thanks. The next set of questions talks about the information that is most critical to your team. What is the information that's critical to your team, and how does it shape the decisions you make? And let's start with Jenkins.
Information is key, right? In our patient flow world within Ochsner Health, my patient flow center team manages all of the beds and all of the movement of every patient within 29 of our hospitals. And there's an exorbitant amount of information that we need to have, and we need to capture, and we have so many different sources of that data and information. And so as we have been trying to evolve and become more sophisticated from a patient flow perspective, we keep thinking about how we can leverage technology. We have consortiums nationally with large health systems that talk about this on a regular basis. And what we have found is everyone's kind of in their infancy with this, just like we are. And we've actually been very fortunate here because we have such a large footprint within the state of Louisiana that we're able to grab a lot of the data that we have for our patient population already, which is not normal or at other health systems nationally. And so we're fortunate in that sense, but we can clearly do better, right? I mean, as I mentioned earlier, we have the EMR, which has a tremendous amount of patient information in it that we already can see and have access to in real time because we have so many patients that we see within our health system in the state. And then fortunately, some of our other health systems in the state of Louisiana also share the same EMR that we do. And so there is some of that as well. But unfortunately, we're still very archaic in the way that we share some of this data. For instance, the patient flow center here at Ochsner now transfers over 40,000 patients between hospitals a year. And the data that we share is still by phone. Our doctors have to call us, tell another doctor, this is what's going on with my patient, and then we make a decision, yes, we can take this, yes, this is what we need to do with this patient, this is the transport modality in which this patient is going to come, this is when this patient is going to come, and this is the facility in which we're bringing the patient. It's all very manual. It's very linear, and it's very manual, and it is over the phone. And so I think that we clearly have opportunity here. Number one, to share the data from an EMR perspective, but number two, to leverage things, the technology such as ambient listening and computers to help us generate ideas on, number one, this patient would be best served going to this facility because this facility has the capabilities of managing this particular ailment and these specialists. This facility is probably the best target for this patient because you have so many patients that are boarding in your emergency department in these three facilities that are also capable of managing the patient. This one has bed capacity, so we can get them in a more timely fashion. And then finally, these are ideas on perhaps this is what's really going on with the patient. Let's work on trying to optimize their care prior to the transfer itself, so that by the time they get to you at the target facility, they're not behind the 8 ball from a clinical perspective. And in those ways, we can leverage technology to, once again, save lives. And that's ultimately our goal.
I think that there are different levels. For me, the most important thing would be the patient. So what I usually think about healthcare care services, I think in the patient level and also the clinic level and the government level. When I said the government, it's more related to the laws and all the regulations that we have. At the patient level, the information that I'm looking for is social determinants of health. Kind of understanding why our clinic populations are not that diverse. And when I'm talking about clinic populations, more specialty clinics. Yes, our primary care services and probably ER are diverse because people are usually in need and they just like go there because they cannot just like handle it. But specialty clinics, I'm completely sure that are not that diverse when we compare to the primary care settings. Even within the same building, you can just like go 2 floors below, above, and that population will be completely different. So when we understand demographics, and demographics is not only about race and ethnicity, and race and ethnicity is something, 2 different groups. I still see them within just one group. But we also need to think about rural populations, low income, low education, and even LGBTQ plus communities. When we think about them and all the needs that they are and why they cannot just like cross that line, like be in the hospitals, we probably can start providing those solutions. That's one on the one side. On the other side is just like educating our providers on how to treat those patients. And then we just unify those groups and start like thinking technology. So yes, of course, if we are like thinking about or talking about low educated, low income communities, probably they don't have technology. And if they were able to have, they don't know how to use it. And I've seen this, I finished a research study 2 or 3 years ago where I was trying to mimic an online platform. This was in Parkinson's disease. So it was funded by the Michael J. Fox Foundation. They had this online study, and they were just concerned why they were just like getting white men, rich, well-educated in their study population. So we designed a study where we have like several surveys and kind of like try to offer the same things that they were like offering. It requires a smartphone, a tablet, a computer. It requires internet, and it was only offered in English. Guess what? The main barrier wasn't trust, because we usually think that trust is the biggest barrier that we usually experience when talking or when approaching diverse communities. The main barrier was language, but the second one was digital divide. People didn't have access to internet or didn't know how to navigate the platform, like a regular questionnaire in using a smartphone, or they just don't even have smartphones. So I think that when we're like providing this solution, we just need to make sure that everything again is going to work. And we probably will be in the point where we need navigators to teach them how to use it. If we are just like moving to be more digitalized, if I can say that.
So again, I absolutely agree, and I'll take it a step further, somewhat simplify it even, and I guess you can tell I'm fascinated with this ambient technology. The biggest, the most important, what's the question, what's critical for us is outcomes. And that's generally based on the patient's understanding of what you're telling them. So one of the largest hurdles is health literacy, and literacy in general, to be quite honest. My experience is that the average person in our community reads and understands health literacy at about a 3rd grade level. There's a lot of word identification. I have hypertension, I have blood pressure, but then when you ask them what it really means, they'll use the word in the word to define for it. But imagine a space with machine learning where we're able to actually listen to the interaction between what we're told in the ER or in the clinic, give it instructions, and then print it out or give it back to the patient in a way that they understand. In the communication equation, we're all educated professionals and we're used to learning from a lectern and an audience. Cortisol kicks in when they call on your name, and that's what happens in every doctor's encounter. You're afraid, you don't remember, which is why we tell people to take someone with them. But imagine a world where we on this side are forced to learn the language of the culture of the person that we're speaking and give it back to them. A sender message equation is a sender message receiver equation. It's actually a bidirectional arrow. It's the equation of debate, right? We might not agree, but we understand each other, and we walk away with a mutual understanding of where we stand. And that's what we want with our patients. So there's a huge opportunity that I'm really excited about with this ambient technology and machine learning, because it's all language, and I'll stick to my guns. It all goes back to the math.
So, Dr. Sanchez, you and I think we agree on a lot of things. I think, what's the adage that 20% of health is what happens in the clinic or in the emergency department? And certainly, saving lives is the most important thing. But what happens when they're discharged from the emergency department, right? Are there health-related social needs that need to be addressed? Having information about whether a person has stable housing, food security, utilities, transportation, so that when something else comes up, are they able to get to healthcare again in time? Do they have the social supports around them to help them with medications? That's important. Those are critically important things. So being able to assess those health-related social needs and then employ services around that individual to meet those needs, it keeps them out of the emergency room, keeps them out of the hospital. So I know New Orleans, the New Orleans Health Department right now is working with Step Up Louisiana to advocate for more affordable housing so that people have housing stability. In our parish health units, we're measuring health-related social needs so that when people come to us, we're not able to provide only WIC and women's health services, but also if they need assistance keeping their utilities on, or if they're concerned about interpersonal violence, we can employ these other community-based organizations to provide those supports. So having that kind of information is across, again, not just a continuum of care, but across all of their health-related social needs, I think is critical to maintaining the health of people in Louisiana.
Thanks. So this is my last question. If we have any time, we can open it up to the audience. I think one of the things that I'm enjoying the most, everybody, is the just diversity of perspectives on the panel. And the last question I'd really like you guys to answer from that perspective. Federal Qualified Health Center, public health leader, and official, large academic center, and academic researcher and innovation officer. Where, in the work that you guys do, what are the one or two things where you see artificial intelligence and machine learning as your greatest assist in the near term? And Angie, we're going to start this one.
That's a tough question. I would say that we need to find a way to close the gap within our own clinics. And I'm telling this because, again, specialty clinics are not the same that primary care clinics or ER clinics. So how we can use machine learning or AI to improve the relationship between doctors in the clinics. So we can make sure that the patient is being seen by all the providers that the patient needs and not just like stuck at the general medicine level and not seeing specialty clinics, even though they have diagnosis that requires to be in a specialty clinic. Yes, there are some softwares that probably can be shared between different hospitals or even different specialty clinics, but I think that there must be a way that we can improve those softwares and make sure that all providers are like using it and like kind of like talking to each other and to provide this kind of like integrated care for our patients.
So, again, I absolutely agree. I actually see the AI as the I'm sorry, my AI glasses are ringing. As the needle and thread sewing the seam of fragmentation between patient and the healthcare system, not just from the system, which is needed between specialty clinics and the social determinants of health community groups and other visits, but between the doctor and patient, the data. I see remote patient monitoring. I am a walking cyborg. I have, like I said, I have the Aura ring on. I have both these on to try to allay people's fear so they can understand what it is that they need to say. Taking the time to explain what exactly your blood sugar is and what it be. The more data that we as clinicians would get, the better we're able to get outcomes for our patients. We know that if you go to a restaurant and you get the spinach dip with the chips, that your blood sugar shoots up 60 points, then maybe you need to slow down. But if we know that and we can identify patterns and come up with a uniform language and a uniform understanding of how the technology is helping us, even on this side, because not all doctors like math. I do, by the way. On this side, to allay the fear of it, because it's here and it's nothing to be afraid of. It's been sensationalized in the media and on the movies. I can remember, first of all, it was War of the Worlds by George Orwell. Then I remember as a kid vividly, War Games, global thermonuclear war. I didn't want to play my Atari for I don't know how long. But again, the way that we attack fear is with education and showing that we're all in this together. And I think that's the sweet spot in the needle and thread that AI can.
So I want to wrap up by saying, I'm okay with that. Fine. I think for the wide range of work that my group and I do, data quality, data completeness, and data collection are fundamental. And it's probably fundamental to any AI work that anyone else is going to do. You come to me and ask me for a data set. I need to make sure that it's correct, complete, and of high quality, and help people understand what the limitations of that data are, so that there is not a bias that's in my data that then is perpetuated in your models. So whatever steps we need to take, including using AI to make sure that our data are complete, correct, and of high quality. So I think that's where we would start.
So I will say I used to love math until I had to start teaching it to my 14-year-old son. And now I absolutely hate math. So I'm going to marry my primary responsibilities at Oxford Health, as an ER physician and in the patient flow realm to answer this question. And I think that for those of you that aren't necessarily in the business of bricks and mortar healthcare, you may not know, and I'm sure you do at this point because it's all over the news, but the finances of healthcare don't make a lot of sense when you're owning hospitals, right? And so, unfortunately, the margins are very, very narrow, and we have to be as lean as we possibly can in order to continue to provide exceptional healthcare to the folks that we have in charge of doing so for. So my answer to the question is actually resource utilization. We have to optimize resource utilization, and one of the best ways to do that is to leverage technology, right? We have to avoid hospitalizations, which again may sound counterintuitive. We have to avoid ER utilization, which as an ER doctor I love hearing because we see a lot of inappropriate utilization. But that entails us partnering with folks in the public health realm, right? Where we have to be able to provide the resources to folks on the outpatient side from an access standpoint in order for us to be able to optimize the resource utilization that we need to have in order for our healthcare infrastructure to remain viable in this country. And so I think that artificial intelligence and machine learning can help us in so many ways with that, right? Because of the information that we can provide to patients, because of the information that we can leverage as clinicians to be able to say this one does have an increased risk of X, and so therefore we need to bring them into the hospital and allow us to utilize that valuable resource for this patient. But that's getting really granular with it, but on a grander scale, realistically, we just need to figure out how to provide access to patients all over our region, all over our country, for those that historically have had inequitable access to healthcare, right? Because ultimately, if we don't do that, we're not going to be able to manage their chronic diseases, which means that downstream, they're going to overwhelm the resources that we do have.
Okay. Thank you all.